Hello, welcome to my channel. So today we'll be talking about chronic obstructive pulmonary disease. So the definition for chronic pulmonary obstructive disease, or COPD, it is a condition that is characterized by inflammation, hypersecretion of mucus, airway obstruction, and alveolar obstruction that is not fully reversible. Okay, then COPD comprises of two conditions, which is emphysema and chronic bronchitis. Then how to differentiate chronic bronchitis and emphysema. So you have to know that emphysema patients are known as pink buffers, so meaning they are not cyanosed. Then chronic bronchitis patients are known as blue blotches, so they are usually cyanosed. Okay, but in terms of symptomatology, they both have dyspnea and a productive cough. Then they also both have burial chest. So the burial chest is one of the important symptoms. Okay. Then in terms of risk factors, so risk factors we can have. So in terms of risk factors, we can have the We can have smoking. We can have advanced age, genetic factors, air pollution, developmentally abnormal lungs, and a low socio-economic status. Okay. Then in terms of pathogenesis and how the symptoms may develop, so in terms of cigarette smoking, so in cigarette smoking, the bronchoalveolar lavage and biopsies of the airways of smokers show increased number of neutrophil granulocytes. Then these granulocytes can release elastases and proteases, so which may help produce emphysema. And it has been suggested that an imbalance between protease and protease activity causes the damage. Then mucus gland hypertrophy in the large airways is thought to be a direct response to persistent irritation resulting from the inhalation of cigarette smoke. So the smoke has an adverse effect on surfactant, favoring over distension of the lungs. Okay. Then in terms of the antitrypsin deficiency, so alpha-1 antitrypsin is a proteinase inhibitor which is produced in the liver and secreted into the blood and diffuse into the lungs. So here it inhibits proteolytic enzymes such as neutrophil elastase, which are capable of destroying alveolar or connective tissue. And alpha-1 antitrypsin is a major serum antiprotease which can be inactivated by cigarette smoking. And when the cigarette smoking has inactivated the alpha-1 antitrypsin, you have to know that then its property of inhibiting proteolytic enzymes that destroy alveolar wall connectivity will be lost. So hence, if someone has alpha-1 antitrypsin deficiency, they may develop COPD. Then you have to know that hereditary deficiency of alpha-1 antitrypsin accounts for about 2% of emphysema cases. Then in terms of investigations, we have to know that the chest X-ray is one of the best investigations, cheapest investigations you can do. So in terms of investigation, the chest X-ray shows the flattened diaphragm and hyperinflation, and the chest X-ray itself is often normal even when the disease is advanced. But the classical features are overinflation of the lungs with low flattened diaphragms and sometimes the presence of large Then blood vessels may be pruned with large proximal vessels and relatively little blood visible in the peripheral lung fields. Okay. Then we have spirometry. So the forced expiratory volume slash the FVC, so it's supposed to be the FVC ratio is usually less than 70%. Then we can do our alpha 1 antitrypsin screening. Then we can do our ABG. So our ABG, so blood gases are often normal at rest, but patients desaturate on exercise, and in more advanced cases, there is resulting hypoxemia and there may also be hypercapnia. Okay. Then for high resolution CT scans, these are useful particularly when the brain chest X-ray is normal. Okay. Then in terms of the FBC, so hemoglobin level and PCV can be elevated as a result of persistent hypoxemia, which of course leads to secondary polycythemia. Okay. Then sputum examination. So sputum examination is not useful in ordinary cases, but where Streptococcus pneumoniae and Haemophilus influenza, these are the only organisms, they are the only common organisms to produce acute exacerbations. Then occasionally moraxella catarrhalis may cause infective exacerbation. Then echocardiogram is useful to assess cardiac function where there is disproportionate dyspnea. So since COPD can cause copulmonale, so maybe you may try to assess cardiac function. Then electrocardiogram is often normal, but in advanced pulmonary hypotension, the P wave is tall. Then there may be right bundle branch block and evidence of right ventricular hypertrophy. Okay, then the chest X-ray findings, or the chest X-ray, how it looks like. So this is how the chest X-ray looks like. So as you can see, where it is pointing to say the mid-clavicular lines, as you can see, there is a lot of space in between. So that's all those big spaces are where we note for hyperinflation. Then the diaphragm are flattened, so there is a flattened, they are flattened diaphragms. Okay, then that's the COPD exercise. So you can pause and try to peruse through. Okay, then in terms of management, of course, lifestyle modifications, so smoking cessation, dietary adjustments. Then there will be use of O2 in late stage. We can use bronchodilators, steroid inhalers, and also vaccinations against pneumococcal or influenza. Okay. Then in terms of physical examination, on inspection, they may have a barrel chest, and if they are in distress, they may use accessory muscles, intercostal and subcostal recessions, and finger clubbing may be there. Okay. Then on auscultation, expiratory wheezing or coarse crackles on lower lobes may be aid. Okay. Then in terms of classification of severity of airflow limitation in COPD from the 2011 GOD stage, so we have stage 1, where the symptoms are mild and the patient is usually asymptomatic, and there is usually no pathologies, so it's supposed to be no pathologies. So no pathologies in the chest X-ray. Then the spirometry is more than 80%, and usually treatment you may use corticosteroids for a short period of time. It's not necessarily a short-term treatment, just a short-term treatment, steroids. Okay. Then we have a stage 2, where there is dyspnea, cough, and chest tightness, but the spirometry is still more than 80%. Then the treatment is still steroids, but you can even put in the use of inhaler. But remember again, steroids, corticosteroids are short-term treatment. Okay. Then stage 3, this is where we have the spirometry of about 60 to 80%, and it is usually worsened. They usually have worsened their signs and symptoms. Then treatment usually put now a short-acting beta agonists such as salbutamol, and again we also go to corticosteroids, again short-term as well. But the salbutamol may be given for some time as compared to the corticosteroids. Then stage 4, this is where we have the spirometry that is less than 60%. Then treatment now, this is when now we go to long-acting beta agonists, so you can end up using formoterol. Then if those things are not present, you can even use ipratropium bromide. Then if still also not available, you can even use magnesium sulfate. Okay, especially in our limited resource areas. So if these things are available, there's no need of using the ones where you only use them in limited resource areas. Then you can also use inhaled corticosteroids again in stage 4. Okay, and usually the patient may require O2 in this case. Then COPD exacerbation. So in terms of definition, you can say this is when there is worsening of the respiratory systems beyond normal variations, requiring change in meds. So in terms of symptoms, there is progressive dyspnea, productive cough, wheezing, and hypoxemia. Then diagnosis, usually it is you use the chest X-ray, of course, the ABGs. Then you can do ECG to rule out a PE. Okay. Then using spirometry and PEFR usually takes time, so just start with the chest X-ray, ABGs. Yes. Okay. Then in terms of management for an exacerbation, a COPD exacerbation, of course, this one usually start with you can use a short-acting beta agonists. Again, if you can also use ipratropium bromide or anticholinergic if needed. Then you can also use a systemic steroids such as oral prednisone on attack or episode time, not for routine use. Okay, like we said, it's not necessary to prescribe them for a long term, but just a short term. Then if there are infections, of course, you can give antibiotics. Then for O2, you can use a non-invasive positive pressure ventilation or a BiPAP. And you have to know that the pressure delivered by BiPAP is lower than the NIPPV. Then also as a last resort, so meaning after you fail the NIPPV, then or the patient fails to respond, then as a last resort, that's when the invasive mechanical ventilation may come in. Okay, otherwise, that's the end of the lecture. Thank you for watching. If you haven't subscribed, please subscribe and hit the bell notification. And see you on the next tutorial.